Thank you for having me here. And you will be asking why someone about diabetes is here talking with you. And I think the answer to that is to hear my charming accent, but perhaps it's not that way. So why are we talking about diabetes? Is it it's not working? Well, I can use this. Okay. So why are we talking about prevention of cardiovascular disease in diabetes? Well, we know, and these are data from the last 20 years, that diabetes is a very strong risk factor for the development of cardiovascular disease. You can see on the left-hand side data from the old Mr. Fit study, in which if you look at patients with diabetes, the red bars, and if you look at the patient without diabetes, and if you look at cardiovascular disease death, the risk is much higher in patients with diabetes, irrespective if the patient have other risk factors for cardiovascular disease, high blood pressure, smoking, high cholesterol, etc. And the incidence of heart attacks in patients with type 2 diabetes, again, on the right-hand side, the red bars, is much higher than the incidence of MI in patients without diabetes, even in people that did not have a prior heart attack or patient that had not. So clearly, diabetes is associated with a lot of heart disease. And if you take patients with diabetes, we know that high glucose levels are also a risk factor for heart attacks. These are data from this large and old study in type 2 diabetic patients performed in the United Kingdom, the UK PDS. And if you take patients with diabetes and you divide it based on their hemoglobin A1C, their average glucose values, the highest is your average glucose, the highest is the risk of developing a heart attack. So we have tons of epidemiological data. Diabetes is a risk factor for heart disease, and the worse the diabetes control it is, the highest is the risk. So what can we do? And why is that happen? Well, we know that diabetes is a prothrombotic condition. We know this by looking, this is a slide of a coronary artery with a thrombus. We know that diabetes affects a number of processes in the body. This is, again, a schematic way to look at this. But if you see, you put diabetes, and diabetes divided in high glucose levels and insulin resistance affect multiple organs, affect the platelet, increase platelet aggregation, decrease thrombosis, affect the liver with more prothrombotic substance, affect the blood vessels with inflammation. We do not know 100% which all these mechanisms that we have studied in vitro, in animal model, which one is responsible, but clearly diabetes is a risk factor for thrombosis. And just epidemiologically, and these are all data, but still it's pretty much the same today, patients with diabetes, they have more heart disease, and the risk and the causes of death in patients with diabetes are for 2/3 heart disease and stroke, much higher risk than patients without diabetes. So now that we know that this is what diabetes is causing, how can we try to work at preventing cardiovascular disease in diabetes? And I'm going to just briefly this morning talk about 3 topics. One is clearly there is the need for patients of diabetes to be very aggressive in managing all the traditional cardiovascular disease risk, from high cholesterol, hypertension, smoking cessation, etc. I'm going to spend a little bit of time showing you the role of good glucose control. We saw from epidemiologically that if your blood sugar is high, you have a high risk of heart attacks or strokes. Does lowering glucose levels prevent heart attack and stroke? And the data there is much more mixed. And then over the last couple of years, we have also found that a few of these agents, newer agents for the treatment of glucose control in patients with diabetes, they also seem to decrease the risk of cardiovascular disease. And I'm going to show some of these clinical trial data. Now, I'm not going to talk about the studies that show that if you manage blood pressure or cholesterol in patients with diabetes, you prevent heart disease. But just to remind you that this approach is clearly working, this is data from 2014, but showing changes in diabetes-related complications over the last 20 years. And if you look at the top, the population with diabetes, the events in terms of heart attacks or stroke over the last 20 years, they decreased by half Clearly, there is a lot more heart attacks and stroke in the country, but this is because the number of patients with diabetes have increased a lot. But if you look at the prevalence, it has decreased, and this is mostly because of more attention to other cardiovascular risk factors. What about the role of glycemic control in the prevention of cardiovascular disease? Being an endocrinologist, I talk about this all day long, and we clearly know that if you lower your glucose control, the risk of eye disease, kidney disease, neuropathy decreases significantly. That has been shown since 1992, 1993. What about improving glucose control? Does that improve cardiovascular disease? And there are a couple of studies that are really important that shows you that. So this is the DCCT Index study that is one of the most important studies for endocrinologists. So this is a study of newly diagnosed type 1 diabetic patients that were enrolled in the late 1980s, and they were divided in two groups, one that were intensively treated, the yellow line, and one that had what was called at that time conventional treatment for diabetes. I'm talking about the 1980s when people were even debating, do you really need to check your blood sugar if you have diabetes? And this is a very successful study that actually now we are following this patient for more than 30 years because those were young people that developed type 1 diabetes. At the end of the randomized trial, which was about 8 years and was published in 1993, there was really no decreased risk of non-fatal MI, stroke, cardiovascular death by improving glucose control. Now, as you can see, the cumulative incidence is very small because these are young people after all. But then when these patients were followed for another 10, 15, and as you can see on the x-axis, now we are talking about 20 years follow-up. After 20 years follow-up, if you have better glucose control, you decrease your risk of heart attack or stroke by more than 50%. So highly significant. Now, you can say this is type 1 diabetes, is very different from type 2 diabetes. Similar, although not as tightly controlled studies have been done in type 2 diabetes. And one study is reported here. This is, again, the UKPDS study. So this is a study that was, again, started in the late 80s, newly diagnosed in this time type 2 diabetic patient, mean age around 40, and they were randomized to tight control or not as tight control. And if you look in the 1997, the study was published at the end of the randomized trial. So there was a 25% reduction. You can see it here. Well, you can see it somewhere in here. 25% reduction in microvascular disease, eye disease, kidney disease, etc. There was no statistically significant difference in terms of MI and no difference in mortality at that time. But when these patients were followed for another 10 years, so now we are talking about 2007, you can see that there was a 13% decrease in total mortality, the same 15% decrease in MI, but this now was highly statistically significant. So again, it takes probably 20 years, and then you can see an improvement in a decrease in cardiovascular disease. And this is in type 2 diabetic. Now, this study was done in newly diagnosed type 2 diabetics. So this is very different from most of the patients that you see or that I see, that they come to the office or come to the hospital because they had 20, 15 years of diabetes. They have perhaps a few complications. And so the study, the question that was asked over the last few years is, what if you have someone that has type 2 diabetes, perhaps have a heart attack already? Are you doing something good by tightening glucose control or not? And these were the three studies that were published over the last few years, the ACCORD, Advance, and the Veteran Hospital Diabetes Treatment, so which were really studies in what about if you intensify glucose control in patients that have a type 2 diabetes and they have a high risk of cardiovascular disease. And so by tight control, the A1C was requested was really in almost the upper normal range. And you can achieve that with any way you shape or want, insulin, other agents, etc. So at the end of this randomized trial, there was no difference in cardiovascular disease. And actually in the ACCORD study, the patients that were more tightly controlled had an increased risk of death, and this study was terminated early. and there was no difference in the other two studies. And again, there are differences in different studies, etc. And then, of course, as you know, an investigator that has a grant for a few years, what you do after you finish your study, you follow this patient for another few years because that is interesting. And so there has been the long-term follow-up of all these trials. And then after another 6, 7 years, what has happened is that in a couple of these studies, there was a slight decreased risk of heart disease. In one study, there was no difference whatsoever. But again, I remind you that in this study, there was also an increased risk of mortality. So the bottom line is that it is much harder to prevent cardiovascular disease in people that already have heart disease and already have significant risk factor for it. Moreover, as you can remember for all these studies, to see an effect on heart disease, it takes more than 10 years duration. And that has clinical, of course, implication for patients that you see on a day-to-day basis. Now, what about instead these new agents that are potentially improving cardiovascular outcome? And I'm going to talk about what in endocrinology we are all very excited about, these new 3 classes of drug. I have just a couple of slides to introduce you to these agents. We probably, as in the cardiology world, these are not the agents that everyone is starting right away. But so the first 2 classes of drug, the DPP-4 inhibitors and the GLP-1 analogs, are basically work on the premise that they increase endogenous level of glucagon-like peptide GLP-1 levels in the body. We all make GLP-1 in our stomach and in intestine. And when we eat, the level goes up. And this hormone has a number of effects. It increases insulin secretion in the pancreas, decreases glucagon, tells the brain I'm full, I not want to eat anymore, and decrease GI motility. Now, why don't we just give a GLP-1? Because GLP-1 is a molecule that has a half-life of 2 minutes, and it is immediately destroyed in the body by this enzyme, DPP-4, dipeptidase 4. So the drug companies, what they've been doing, have developed analogs of this molecule, or they're developing blockers of these enzymes. And so you have the 2 different classes of drugs, GLP-1, and these are the names of the FDA-approved GLP-1, or DPP-4 inhibitors. And I'm sure that you all recognize Januvia, Onglyza, all these names, etc. Now, the difference between these, there are many differences from the endocrine point of view between those classes of drugs. One is that these are injection and these are pills, and these induce weight loss and these do not. No. But they all work by increasing endogenous level of GLP-1. And then we have now these new drugs, which are what we call the SGLT2 blockers. So what happened with these drugs? In the kidney, glucose is filtered, but 90% of glucose is reabsorbed in the proximal tubule by this SGLT2 transporter. We all have that. And then we also have SGLT1, but that is count only for 10% reabsorption of glucose. Now, there are some humans, probably, perhaps even one in this audience, that have a mutation of this gene in which the SGLT2 transporter doesn't work very well. These humans are perfectly healthy. They don't have any disease. They live a happy and long life. Well, I assume happy and long as we all live. But what they do is they spill glucose in the urine. And you just find these people by measuring urine glucose in someone without diabetes. Usually it's negative, and those are positive. So the drug company said, what about blocking this molecule? Then in patients with diabetes, you are going to lose glucose into the urine. And nowadays, we have a number of pills that they do that. One advantage is that are easy agents to use, and you really do not induce hypoglycemia because you just decrease a little bit your plasma glucose, but if your plasma glucose is normal, it remains normal. Okay, so these are the 3 classes of drug, the DPP-4, the GLP-1 receptor agonist, and the SGLT2. Now, since 2008, the FDA has required a drug company when you want to introduce any drug that treats diabetes, because diabetes is such a risk factor for heart disease, you need to do cardiovascular outcome to be sure that you are not worsening heart disease in diabetes. And this is just showing all the studies that have been done over the last few years by the different drug company on the to be sure that these patients are not at risk for heart disease. And those are studies done in type 2 diabetic patients with long duration of diabetes that either have a lot of risk factor for heart disease or they already have heart disease. And when they started to do this study, at the beginning they saw that, well, these agents do not cause bad effects on the heart, do not cause any good effects on the heart, but they are neutral. So DPP-4 inhibitors, there is really no advantage, no disadvantage in terms of heart disease. But then a few other studies came out. The first one was the study of the EMPA-REG, which is empagliflozin, one of these SGLT2 drugs. The commercial drug name is Jardiance. And when they look at this, they found that there were significant improvement in cardiovascular outcome. Just to summarize, there was the risk reduction in terms of the cardiovascular death was 38% reduction. All-cause death was 32% reduction. Cardiovascular outcome was, 34%. So this drug was very powerful, and the cardiovascular benefit was already evident at 3 months. Then there was another study. This is instead the liraglutide study. Liraglutide, trade name is Victoza, one of these injectable GLP-1. But again, the same studies, large patient population, and again, here they showed that there was a significant decreased risk in terms of cardiovascular death, all-cause death, and the primary outcome that was death and MI and stroke. So this became very exciting, and actually these two drugs now the FDA has approved for the treatment of cardiovascular disease in patients with diabetes. Now, these studies were done in patients with diabetes and cardiovascular disease, so we have no idea if you take this and you have diabetes but you don't have heart attacks or strokes, does it prevent cardiovascular disease? We do not know as yet because such a study has not been done. And this is the latest this year released, the CANVAS study, which is again is Invokana, canagliflozin, which is another of these SGLT2 that has roughly similar effect. So if you look at here, now you have two drugs in the GLP-1 agonist that have positive effects. I didn't show anything about this drug because it's not FDA approved, it's available in Europe, and these two other drugs in terms of SGLT2. So I'm going to close here and have a few minutes for question is, so we know that patients with diabetes have a high risk of heart disease. We definitely know that. And we know that a traditional cardiovascular risk factors are essential in keeping blood pressure, stop smoking, cholesterol levels in range is important. We know that from the onset of diabetes, good glucose control eventually prevents cardiovascular disease, but it takes many years. And for the patient with established cardiovascular disease, the risk of tight glucose control is really not well clear, depending on which study you look at, and there is a lot of debate. Now, some of these newer medications for diabetes decrease the risk of cardiovascular disease in patients that have established cardiovascular disease, and some of these drugs are pretty easy to use and potentially beneficial. And what we still do not know is about are these drugs also preventing cardiovascular disease in patients with diabetes without prior history. And of course, to do that, you really need a large study that lasts many years. So the study that I've shown you, they've studied about 3-4 years with about 15,000 patients, and doing a preventive study will require much more than that. But I think I'm going to stop here, and I'm going to wait for some questions. Thank you.